Good morning everybody. Actually today we are going to demonstrate total contact cast. Here is a patient. You can see patient is lying here and it is a demo patient. So obviously there is no actually scar or open wounds like that or diabetic ulcer like that. But in case of diabetic ulcer or there is open wound or there is infected diabetic wound, so how we will do a total contact cast? Today we have with us Professor G.G. Kaur. So sir will demonstrate the whole things. I just handed over the mic to Professor G.G. Kaur.
Okay, then before we start, let me introduce what is TCC. Most of the people know what is TCC, but it is totally different from the Biloni cast, which orthopedicians apply for fracture, for after treatment, etc. Because the concept is to try to heal neuropathic ulcers. Neuropathic ulcers were predominantly in leprosy, and the whole thing has evolved from treatment of leprosy.
Yes.
And it evolved in this subcontinent, in Sri Lanka and Tamil Nadu, the southern part of India. You know who popularized this, and then this thing was adapted for diabetic neuropathy. Now, if there is a gross infection, then this cast should not be applied. And if there is a huge amount of discharge or there is a gross deformity of the foot for some reason, that is why for many leprosy patients you cannot apply TCC. And I come from an area where leprosy was endemic, so TCC type of cast is not foreigner for me. For many years when we were just house staffs, we saw how our teachers applied this cast for treating leprosy patients. Nowadays we have the diabetic capital of the world. This is the diabetic capital of the world, and many patients with without any electrolytic problem, only for diabetic polyneuropathy, they come with us for treatment of poorly healing, non-healing, delayed healing ulcers, and also some Charcot's disease. So it can stabilize the Charcot's disease, Charcot's foot, ankle area, and it takes the load off the forefoot ulcers and midfoot ulcers. It is not very convenient for hindfoot ulcers. In fact, many people tell us that for hindfoot ulcer this is contraindicated because it shifts the load from forefoot to hindfoot. And it also works on the principle of total contact. That total contact is slightly misnomer because nothing can be 100% contact with the plaster, cannot be in the 100% contact with the skin. Something has to be in between those two. But contrary to the popular Biloni cast, here we have minimal amount of any padding between the plaster and the skin. Okay. The initial layers are for convenient those plaster of Paris, and the shell again is reinforced by synthetic cast. So to start with, we need several things, and it is a time-consuming affair. It's not a very fast affair. Takes quite a long time to apply this. Preparation starts with, here this patient does not have any ulcers. So preparation in a real patient starts with preparing the ulcer. The ulcer has to be debrided. Most of the patients are neuropathic, do not have sensations that much, so debridement can be done as an office procedure. After that, you have to have the margins of the debrided area as like a suturization in your bone. It should not be the mouth of the ulcer should not be deep, should not be narrower than the base of the ulcer. Rather the opposite. The base of the ulcer should be narrower than the mouth of the ulcer. If there is infolding of the ulcer, you have to debride it circularly, and then we know how much area we have to protect. For protection, we need some padding here. Now suppose this is the area of your ulcer and you want to protect this with this kind of padding. Okay. Now this padding, you see, is having a rectangular cross section. We must skeeve it from the sides so that the load is evenly distributed. So with a sharp knife, skeeve it like this from all aspects. This is just a rectangular. In practice, it will be a circular one. So skeeve it like this. Now if you place it here, you see pressure distribution is more even when the patient will be working. The idea is to make the patient work. Of course, the surest way to heal any pressure ulcer anywhere in the body is to offload. If the patient can lie down for 3 months, then the ulcer will heal in the foot. But that is not a goal. Our goal is to make the patient work a bit. It is not a plaster to work around in the roads. It's just for indoor working and doing the basic ADL, activities of daily life. So that is the goal here. So you skew it like this on all the edges. If it is a circular one, you skew it like a this side also. So that is the way to place it on the ulcer. So you use a non-adherent dressing first. We are skipping that because there is no ulcer over here. This can be done in 2 ways, with the patient supine or with the patient prone. Okay, both have got their advantages and disadvantages. When we make the patient supine, you require assistant always to hold the limb. Vis-a-vis, when you make the patient prone, you don't need an assistance. The downside is when you are having the patient supine, please relax. Relax. Let the patient relax first. Okay. Otherwise, every muscle will be contracted and the whole thing will become stiff. So the advantage is that in this position, the patient's natural equinus is maintained. Natural equinus. Downside is that you have to hold this sometimes and then hold this. Okay. In prone position, the making of the technique is very easy because the 90-90 position, the 90 position of the knee joint and the 90 position of the ankle joint will be maintained easily by pronating. Making the patient prone. Downside is that because of the gravity, sometimes there is dorsiflexion. Okay, dorsiflexion in this kind of cast is not a good thing because it will shift the load into the hind foot, and the hind foot will not bear, forefoot will not bear the load distribution. So that's all. So now we, for this demonstration, because he has no ulcer, we will use for our ease in a prone position. Prone position of the patient and 90-degree flexion of the knee joint. Here you have to maintain the foot in slight equinus, okay, not in dorsiflexion. So calcaneus is not permitted. This is the way, and the patient, because he is conscious, he can maintain this position for about 30-40 minutes without any problem. In case of problem, he will have to be pacified. Okay. So now I will apply this sham, this thing, padding. Actually it doesn't have ulcer, so it's a sham thing. Anyway, give me a padded dressing, small padded dressing. This is a padded dressing, Licobed, 8x15.
Change to 25.
It has got bigger dimensions also, but those big ulcers are very, very uncommon. So I am placing this on a ulcer which is not there, but it will be there when you are treating an actual patient like this. So done here, okay. And after this, we will protect this against this one and hold it like. Suppose this is the area we are protecting, and to keep this in this position, we will need a bit of paper tape. To hold it in this position. So nothing costly, only commonly available things are being used. Anyway, those leprosy patients were poor patients. So now we will apply kind of stockinette snugly. This stockinette should be a slightly stretchable one, not a non-stretchable one. This should be from the tibial tubercle downwards. Remember, these patients, unlike your fracture trauma or other operations patients, will not be able to tell you that there is pain in the sole.
Yeah.
So if there is a pain in the sole, they will not know about it. You will not even know about it till there is a bigger ulcer than what you are trying to treat. It's very important that there should be no creases anywhere in this. Now one crease is almost mandatory here because we have redundant skin like here. So we'll cut this with a knife or a sharp scissor here on the entry aspect of the ankle area, because this is an extensor surface. So we will cover this up as snugly as possible. Now see, there is a crease over here also, so we will cut more. Avijit will cut on the medial side. And this we will stabilize with paper tape. We'll split this vertically into two. One will be applied here, one will be applied on the side, on that side. So now here is a hollow. You see, just below the lateral malleolus and medial malleolus there are hollows. In these hollows we can tuck these folds. Okay, that will not cause any pressure because they are hollows. Now we will protect our malleoli. Okay, so for protection we need some kind of foam. These are commonly available materials in any hardware shops, any bedding shops. So take out a liberal amount of these foams. Of course, medical foams are available, but they are costly and not available everywhere.
So it is available in any bedding store.
Any bedding store. That is the beauty of the thing, that this does not require hi-fi things. This is basically low-fi thing. One malleolus. And that is split. Piece of paper. Another piece will be required, of course, for the medial malleolus. So this is just so that it stays in place when you are applying the next layer of paper. This is happening on the other side, but this is just a repeat of this thing. Okay. Now what will happen with this? In a conventional cast, we cut this and fold this. Here, the toe box will remain closed to our eyes. The purpose is well known, that so that the patient does not get stuck on furniture or edge of the floorings. That is, this should be protected. Now we will cut this extra portion off. So this has started with the tibial tubercle and has come to the beyond the toes, and now there are two ways to use this, two ways to tuck this. One way is to tuck dorsally like this and hold it with the vapor tape. Another way is to, there is a hollow at the PPA, the proximal phalanx area, proximal phalanx, middle phalanx area. So there it can be tucked in that also. That will produce a nice smooth snugly fitting, and the contour will become smoother.
Yeah.
So now we can put it here. Both methods are applicable. No problem. Personally, I think this is better. So you see, because the patient is conscious and cooperating, probably you are cooperating, na? Okay. So because the patient is conscious and cooperating, we need minimal inputs from our assistants till now.
Yeah.
After this becomes slightly heavier, we will need. And remember about this padding here. Can you show me the problem? Can you show this padding? So that the patient's patella remains happy. Huh? Okay. Now we will put a layer of, in his case,
Soft roll.
Soft roll is a trade name. In this case, it's a generally the cast padding. So we will not tear our hairs over whether it is soft roll or articulates. Now again there are two ways to place this. One is to isolate this one first and then go for this, apply separately. But here continuous application is also very applicable, very easy, and it is also known to every casting technicians, every orthopedicians. So we'll go with about 50% of overlap. You see, this is 50% of overlap I am attempting for. Again, there should not be any creases. Anyway, this is a very soft material, so no problem will be there. The creases fortunately happen in the hind foot, okay, not in the forefoot. And as I've already told, hind foot ulcers are not to be treated with GCC. Hind foot ulcers are also very rare in case of diabetic foot, fortunately.
Mainly forefoot
and midfoot ulcers like the patients. So this is just the 50% overlaps till the whole length is covered. So this is the basic difference with the. Can I get another cast padding, articast?
Artiflex.
Sorry, artiflex. I'm poor with the brand names. So this has to be tucked in like normal cast padding applications. To my right side is a renowned physiotherapist of our city, Mr. Alok Nag. So I'll cover this up and cut it over here. Can I get some water, please? So this is almost complete your first part of the thing. Now comes the extra part. Extra part is you have to protect the foot toes. Protect the toes. That's why we need a half-inch foam. Again, easily available in per square foot basis in any bedding shop. Now the idea is to cover this up like this. The whole area has to be covered. So we'll get this much cut off. Rather to take some extra portion, you can always skim that off. Width should be more or less that of widest portion of the foot. This is the widest portion of the foot, the first metatarsal to fifth metatarsal, first MTP joint to fifth MTP joint. So this is the widest part. We have. So the foot itself is templating. So now we cut this nicely as a rectangle. The principle is same. Now commonly what happens, this area and this area, like your amputation stump, gets a U shape. Here you have to skim it off. But that can be done just after the application. Paper tape for stabilizing this also. Maybe I am not happy with the length, so I have to trim it off a bit. It should be around midfoot, not going up to the ankle joint. So this is totally different from a conventional cast. Without chopping of the little toe, without chopping of the great toe or its protection. Nicely fitted. Okay. The rest of the thing is just like a orthopedic casting. You start with a plaster of Paris bandage, but slowly. I have to have some water. Before I start, so we start with here. Ultimately, we'll cover the whole thing, stabilize there
From distal to
from
proximal.
distal to proximal, because if I put proximal and it becomes tight, then there will be venous stasis, and in venous stasis for a diabetic foot ulcer can be
It's not at all.
very problematic, and it can actually increase. Now you see this natural about 5 degree to 10 degrees, 5 degrees to 10 degrees of equinus is maintained. Okay, this has to be consciously maintained in a prone position, because the natural tendency of the gravity will be to make it 90 degree or even 0 degree or even dorsiflexed. So here every layer has to be rubbed off and polished before I put the next layer, and as far as possible, because this is very close to the skin, only one layer of 50-50 overlap cast padding was applied. Even then, after about 7 days, you must inspect about for the loosening,
Yes.
because after putting this, much of the inflammation goes off very easily, and that is
The
helpful for the
is-
patient.
Swelling is
Swelling
automatically
gets
reduced.
so the
So
cast
there
will
may
become
be some loosening.
Yeah.
Patient complaining there is
Yeah.
a lightening of this.
Right. And sometimes if the polyneuropathy is widespread, patient may not know about it. In this, you don't take away from the skin, because if you take it away from the skin, there is a chance you are putting too much of pressure. So just roll it on the surface, like this, and take enough amount of time. Just roll it on the surface. That way we will not produce extra pressure. We do not need extra pressure. This is just contact. Contact we need, not the pressure for close treatment of tibia fractures.
Yes.
There we need a hydrostatic effect as described by none other than Professor Sarmiento. But here we do not need that. We need
Just roll it
and
around the
whole contour.
whole contour of the
And the contour will be followed when you complete your casing cast. Then the cast will not look cylindrical. The cast will look like a slightly elliptical, just our cross section of our normal leg. And we have to remember these patients may have some deformities also
Yes.
prior to coming to you. Don't try to correct those deformities with the cast. Keep it there as such. You fit your cast according to the contour of the patient, not the other way around. Don't try to make it look a nice cast, a cylindrical cast, and be careful about those prominences here. Now there is a concern of when you are taking the cast off of having the skin cut, because if somebody takes my cast off, I don't have neuropathy, I will jump, and then and there the cutter will know that the skin is being cut. Here the patient, because of polyneuropathy, may not know about this, so there can be
Sensation is always
always
less
problematic.
than the
So
normal.
it is better to have give me the black thin one, this kind of thing over the shin, okay, a thin layer over the shin, just in this layer or deeper to this layer, okay, when you are cutting this, because we will be having a shell of hard plaster,
Yes.
that is the, not plaster but cast material, synthetic cast material. When you put the saw through it, that can be grazing it can be grazing the shin, because shin is very so subcutaneous, the skin can be caught between the hard bone and the saw. Okay. Now another layer will be put here, and for ease
Before
of
that, yeah.
and for ease of removal, we will put this here, so that our beloved volunteer does not get his skin cut
Does not have any heart.
and does not have a grudge against us. Again, See, when you are doing this, you will have to skip this area off. I am not showing here. Skip this area off, skip this area off, so that there is no contour like rectangle. So these all have to be nicely smoothened three-dimensionally. This dimension as well as in this dimension. These small things are to be kept in mind when in detail when we are going for. See, now this is skipped. Okay, this is not rectangular. You can compare with this. This side is rectangular. This side is triangular. Okay, so it should cover this area. I usually put in this after primary layer of POP.
Yes.
You can always put it inside also, between the POP and the stockinette, even before application of your cast pad. Can be done. So now we start with another layer of plaster of Paris. Just holding it is enough. So he has got a long leg. Number 3 is also going down there. Now we will cover this area. So it is a blind end for the surgeon, blind end for the patient. And there is a relative contraindication of TCC is a blind patient. This is to protect the, this serves two ways. Number one, protects the toes and the forefoot area, plus it also prevents sliding of the cast downwards. Sliding of the foot inside the cast downwards. Suppose there are mechanics, biomechanics, everything involved. So far this is called the gold standard, na?
Yes.
So far this is called the gold standard in diabetic foot care, where the ulcer is not readily healing, and you allow your patient
To walk
to work inside the home.
and as well as the ulcer should heal by this time.
As I have already told that the best way to heal the ulcer is to make the patient bedridden for
3 months.
3 months.
Even
But that is
sometimes more than that.
not more than that. Okay. Now we will apply the shell of synthetic plaster. So what synthetic material we used?
Articles.
Articast. This is
5.
5 inches, 12.5 centimeter. There is no specialty in application of this. In our hot humid atmosphere, we do not need it to dip into the water. We just apply the water. Again, we start with the dorsum of the fore and midfoot. Gradually go. Now you can have freedom of using this in any way you like, because if there is a crease over here, it will not be transmitted into the skin area of the patient. Anyway, this is stretchable, so there should not be any too many creases. If there is a crease, you can always smooth it out. Please keep the water around very near to the outside of mouth. So when you go, you smoothen all the junctional areas. This is a junctional area, this is a junctional area. You smoothen these as you go with a little bit of water. So margin of the synthetic should be slightly less than the margin of the POP. Incorporate the here at this stage the stockinette material in this stage. So the stockinette will be slightly proud. If necessary, you can have a cut with a scissors or a knife. To allow for the asymmetry, conical shape of the so this almost finishes the whole procedure. Maybe because he is a tall man, we need another
5 inch.
another 5 inches or maybe 4 inches also. Just smoothen this junctional areas. This is standard. This is standard for any casting procedure of the body. Because this material is a woven material and the resin resides in between the small rectangles. So all the rectangles should be smoothened out to give the resin as much power, as much strength as possible. So should I proceed with this
No,
thing? I
there
think
is
this
no
is fine.
need. This is a demonstration
This
purpose.
will be covered also.
Yes.
This will be covered also ultimately. Okay, I'm not.
So we
going
have
back.
another
We are not
for
wasting
to
another.
cover the,
Yeah.
but here we just show this, and this is the whole thing.
This is the whole thing. This elevation is there for the lateral malleolus because this elevation contains a padding material. Here inside there is a padding material, and I'm not bothering about this because this is below. This is in the hind foot. It is not touching the ground,
Yeah.
and anyway it will be covered with another layer of synthetic plastic. So I think this is it for now.
Yeah.
Thank you.
Thank you for watching this, and many more will come.